So now I changed from the introduction to the chair of the first panel session. So as I already said, the question is health economics research having an impact on policy? This is of course a very, very difficult question. When trying to think about this question, I think that the answer is obviously yes, but question is how. There may be very, very indirect ways in which health economics research and more generally economics research may have an impact on policy, but it may be very diffused, maybe through the diffusion of ideas. It's very, in short, what we have to address this question is a major identification issue. It's going to be very difficult to pinpoint one specific work in economics which has one specific impact on policy. And but this is something that we're going to try to do. So there is a change, last-minute change in the program. So Carol Proper unfortunately could not join us this afternoon, and we think about her. And she's been so we're going to have 4 speakers, and so Marisa Miraldo, who is not on the program. Well, she is actually on the program, but she was scheduled later on, and she is now going to be scheduled now. So I'm happy to welcome Andrew Street from York, who is going to talk about paying for hospital specialist care. So have this kind of work had an impact on policy in the UK? That's one of the questions. Then Pedro Pita-Barros will talk about the good, the bad, and the ugly of policy advising. So we are very, very anxious about these talks. And Luigi, also from York University, will talk about optimal price setting and pay for performance schemes in healthcare. And then Marisa Miraldo will talk also about payment for performance. So of course, P4P, payment for performance, is an important issue. Is of course one specific question on which health specialists and economists have things to tell, things to say, things to discuss with each other. And does it lead in not only in policy but also in good policy? Okay, does it lead to impacts on good policy? Actually, we could. I think maybe next year, or maybe in 2 or 3 years from now, I think the question that we're going to ask is health economics research having an impact on population health, which is going to be an even more difficult question to address. But so let us go progressively. Research is made by bits and pieces. So and let's start with this. So each of you has 20 minutes. There will be lots of time for discussion with the room. Don't hesitate to prepare questions to our speakers. And we will start with Andrew. So 20 minutes, and I will be very, very strict.
Thank you.
So you
Thanks. Well, thank you. Merci bien, Pierre-Yves. Merci beaucoup, Lise. And I'm going to argue that we do have a big influence. And Lise asked me to show this work because the results of this work have resulted in millions of pounds being allocated differently in the healthcare system across the hospital sector in the UK, in England, not the UK, in England. So this work is fed directly into it. We still do have a United Kingdom, contrary to what we might have thought a couple of weeks ago. So this has influenced the payment policies by which hospitals are paid in England, and as a result, of course, hospitals are really quite interested in this work, and I'm seen in various degrees of popularity by different hospitals in England, for reasons which you may become clear later on. I'm going to kick off really by just going through a little, showing you some debate that happened in the House of Commons a few years ago. This is Tony Lloyd. He's the Labour MP for Central Manchester. Central Manchester has quite a large children's hospital in his constituency, and in the House of Commons he asked this question of the Secretary of State for Health. He said, the Department of Health has written to specialist children's hospitals threatening to withdraw money that is critical in treating the most critically ill children. This is Frank Dobson. He's a Labour MP for Holborn and St Pancras, which is in London. In his constituency is the Great Ormond Street Hospital, which you probably know of. He asked this question: how can Great Ormond Street, in my constituency, face a reduction of income of £16 million? Andrew Lansley was the Secretary of State then for Health. He's not the Secretary of State now, fortunately, I think. He's done his best to dismantle the healthcare system in his time in office. This is him. And this was his response to the questions that were asked. He says, the Department of Health has acted on the basis of a review conducted by the University of York. So, blaming me for the fact that Great Ormond Street is facing a big income reduction. Central Manchester hospitals are facing a big income reduction. Now, bear those two hospitals in mind, because I'm going to come back to them during the course of this presentation. If we think of specialisation as economists, we generally tend to think that specialisation reduces costs. That's what Adam Smith tells us many years ago. And there is evidence that if you specialise, you do get lower costs. And there is evidence from the healthcare system as well about that. So, for instance, we've introduced treatment centres in England over the last few years. Treatment centres are designed to specialise on just one or two procedures. They just do hip replacements, they just do knee replacements, they just do cataract removals. And those treatment centres tend to, the evidence suggests, they tend to keep people in hospital less than they would if they were treated, equivalent patients were treated in hospitals. The costs are lower, and actually the quality of their care is better. So for treatment centres, specialisation reduces costs. But around the world, what we tend to find is specialist hospitals tend to be quite well funded, often better funded than general hospitals. Why might that be the case? Well, there's two reasons, I think. One is they exert greater bargaining power. They can get their MPs to ask questions in the House of Commons, as we've just seen. So that might be one reason, and I'm going to come back to that at the very end of this talk. What we can do as health economists is address the second question. One of the reasons they might get better pay is because actually they are attracting patients with more complex care requirements than equivalent patients, well, patients that are paid an equivalent amount who are treated in general hospitals. And it's this question that I think we need evidence on. And it's this question that I was asked to provide evidence on for the Department of Health to inform the funding arrangements for specialist hospitals. In England, we have a prospective payment system, and essentially that means that the revenue, in very simplistic terms, the revenue that a hospital receives is basically related to the quantity of patients being treated, how many patients are being treated, and the price that is paid for that treatment. So that's a very simple form of the revenue function. Of course, it is more complex than that, but in its core component, that is what it involves. So, if we're going to have a revenue function that looks like that, we need to specify two things. We need to specify quantity, and we need to specify price. So, quantity is basically the number and type of patients being treated. And price and a prospective payment system is fixed in advance. And the price is fixed basically by looking at the costs of treatment across the whole sector in England. And those costs are then converted into prices. So I'm not going to say too much about the price, because it's not so much the price. Well, the price is how we make adjustments. But it's the quantity that is defining the quantity that has caused concern to specialist hospitals. Because how we define quantity in England is using a system called healthcare resource groups, which are analogous, not quite the same, but pretty much the same as your groups in France, your groupe homogène de malades. So you have about 2,000 groups, we have about 1,400. but essentially they are designed to do the same thing. So your payment system in France is similar to the payment system that we have in England. And the concern in France, as in England, is whether these groups are indeed homogeneous. They may not be. They may not be exactly resource homogeneous. And it may be that patients that receive specialised care may be more costly than other patients allocated to the same group. And if that's the case, then the payment system, based on this grouping mechanism, will systematically underfund specialist hospitals. So that's the concern that was raised by specialist hospitals in England, and it might well be the same sort of concern that is raised by hospitals in France as well. So we need to work out whether that in fact is the case and what we might be able to do about it. So there's a couple of analytical tasks to solve that problem. The first one is we need to define what specialised care is. And the second thing is when we know who's had specialised care, we need to be able to work out whether those who receive specialised care are indeed more costly than those who do not within the same payment category. So our work is designed to answer those two questions. Pictorially, this is what we try to do. We have costs for every patient in England treated in hospital. So we have a nice data set on all patients in England. And if we look at their costs, we might have a distribution that looks like this. Costs tend to be skewed with a very long tail of some very expensive patients in hospital and a bulk of people at the bottom end here. I wonder if this actually works, the pointer. Here, yeah, okay. So we have patients here, and then we have costs along here. So some patients are quite inexpensive. We have a mass of patients here, and then we have some patients with who are very costly. So that's our distribution of costs across the whole population of patients treated in English hospitals at any point in time. What we want to do is work out why somebody might have a cost here, sort of at the average, and somebody else might be more expensive. What are the reasons for why they are in one part of the cost distribution and rather than another? Well, one of the reasons might be because they're in different groups. So you'd expect more complex and costly groups to be at the upper end of the distribution. So our analysis needs to take that into account. It could be that over and above the groups they're in, they might receive specialised care. Are people who receive specialised care more likely to be up this end of the distribution rather than this end? It could be that they're treated in inefficient hospitals. If the hospital's inefficient, badly organised, ramping up costs for things, then patients are going to be up here rather than down there. So our analysis needs to take that into account. And of course it could just be chance. There could just be random variation in what drives costs. Random variation means we can't explain everything given what we observe about patients. So our analytical methods need to be able to disentangle those different explanations as to what drives differences in costs among different patients. So to do this, we're going to analyse some data. We have quite good data. We can't get the data at the moment, which is very frustrating, but we have data for a number of years. And we've done this analysis for 3 years' worth of data, 2008, 9, 10, 11, 12. The data we've just analysed using 11-12 we published 2 weeks ago. So the report on the latest on this data is just come out. I'm going to focus on the 9-10 results because that is the set of results that are currently embodied in the payment system in England. So we have a lot of data for 3 years, and we have approximately 12 million patients a year for whom we can undertake the analysis. So, you know, a reasonably large data set to get our teeth into. It's quite nice and powerful. With these data, we need to first of all define what specialist care is. Now, over time, the definitions of specialist care have changed in England, which has caused me a bit of a headache this last year in doing the most recent work. But anyway, I won't bore you with that. Essentially, in 8, 9, 9, 10, we had a specialist services national definition set. And now we have a prescribed services definition set. Both definition sets basically use specific diagnosis or procedure codes in the patient's medical records and look at the patient's medical record to see if those disease codes or procedure codes were present from a specific set of lists. So clinicians have gone through disease codes and procedure codes and said, if this patient has got this diagnosis code and has had this procedure, then that is indicative that they had specialised care. And if that code isn't in their record, they didn't. So we can look at the records for all 12 million patients and see whether those disease diagnosis codes or procedure codes are present or not. And if they are, they had specialised care. If they're not, they didn't. And there are, of course, lots of different definitions of specialised care. So it's not only whether they had specialised care, but also the type of specialised care. So for every patient, we can identify whether and what type of specialised care they received. So this is an absolutely crucial element of the identification procedure. And that's done for us by the clinical community in England. So we can take that and use it to analyse our data. So for 910, this is what we find. We had 12 million patients treated during the year, and 1.3 million patients had some form of specialised care. So, you know, just over 10% of people in England receive specialised care, according to the definitions used in 910. And you can see that there are differences according to the type of specialised care received. So 131,000 children had specialised care. So it's important for the children's hospitals. 24,000 women received specialised care, and only 338 people in the whole of England received specialised rheumatological care. So the numbers that you identify vary considerably according to how we define specialised care and the type of specialised care in question. Now this gives you quite a different picture of specialisation than if you looked at the labels that hospitals give themselves. Because some hospitals say they're specialist. Well, how much work do they actually do as specialist hospitals? Great Ormond Street does a lot of specialised work. 72% almost of patients treated in Great Ormond Street receive specialised care according to the national definitions. 41% of children treated in the Central Manchester Children's Hospital receive specialised care. No wonder the MPs for those two hospitals are asking questions in the House of Commons, because how we define specialised care and how we fund it has a big impact for those two hospitals. But look at these three hospitals. We have Birmingham Women's, we have Liverpool Women's Hospital. They both say they're specialist hospitals. They label themselves as such. Only 1.5% of patients treated in Birmingham Women's, less than 1% of those in Liverpool Women's, actually receive specialised care as defined by the people who were being treated in those hospitals. In the National Hospital for Rheumatic Diseases, only 0.1% of people receive specialised rheumatological care. It's not really surprising given that only 338 people in the country receive specialised rheumatological care. But you get a different perspective if you look at an individual patient level than you would if you looked at the hospitals, how they label themselves and say what they have done. Let's look at the costs then. On the face of it, if you receive specialised care, you're more expensive. This is the average cost to people who receive specialised care out of the 12 million compared to those that did not. So without controlling for anything, patients who receive specialised care tend to be more expensive, £1,900 compared to £1,300. It looks like there's something going on. What is it? Is it the specialised care though? Is it the GHM that they're in? Is it the hospital that they're treated in? Well, we're going to disentangle that by looking at a regression analysis to explain why costs differ from one person to another. So we take account of the GHM, we take account of what type of specialist care they received, the hospital they were treated, and random variation. As a a regression model. And what we find are the following. We find that specialist care doesn't always translate into higher costs. So for some of the specialist markers, people have received specialised care, but it doesn't necessarily mean that they're more expensive than other patients allocated to the same group, the same payment group. But for some types of specialised care, costs are higher. So patients are allocated to the same group, and those that had specialised care tend to be more expensive than those that did not receive specialised care, even though they are funded on the same basis. And this is just some examples. Specialised neurosciences, patients who had specialised care are 16% more expensive than others in the same payment group. For orthopaedics, the cost differential is 22%. For spinal surgery, it's 27%, and for children, it's 20%. Now, you'd think, looking at that, that the children's hospitals would be really happy with me, wouldn't you? Because I'm saying, yeah, you're seeing more specialised patients, and yeah, they're more complex and more costly. You should be reimbursed 20% more over the base rates because your patients are indeed more expensive by 20%. Children's hospitals weren't happy with me. The reason they weren't happy with me was because when I did the analysis, there was already a payment arrangement for the specialist children's hospital. The payment arrangement that they got was 78% more than what other hospitals were being paid for treating children. Almost twice the amount. Now, of course, they weren't happy because I'm saying it's a reduction on what they already had. Of course, the analysis that was undertaken for this work was quite crude and incorrect. So the children's hospitals do not like me very much at all because I'm saying that their costs should be reduced. So why do we pay more to specialist hospitals? Well, it is because specialist hospitals attract patients with more complex care requirements, and our analysis shows that that is the case. But they might end up being paid even more than that because, as I said, specialist hospitals exert greater bargaining power than perhaps non-specialist hospitals. And I'm worried about that. I don't think it's fair. I don't think it's fair because in the UK, in England, and in the UK, and in France, usually we have a fixed budget. And that means in a fixed budget, if some hospitals get paid more because they're able to exert more bargaining power, it means other hospitals get paid less. The specialist hospitals might be good at getting extra money because they're able to lobby, and I'm sorry if some of you are representatives from specialist hospitals, because you're the ones who are going to be able to lobby much more effectively. But if you're from general hospitals or local hospitals, who's representing you? The children getting paid more money in the specialist hospitals, that money is being denied to my local hospital, my general hospital, where children are also being paid. So I believe that there is essentially a gap between how payment policy has been designed in the past and what it should be. And the evidence that I have provided is designed to make that gap smaller and to provide an evidence base by which we can make much more informed, evidence-based payment policy for hospitals in England by disentangling those two things. I think we have a handle on this issue, the latter issue, about complexity, and our analytical methods allow us to do that. And that means we can move away from a system where funds and budgets are determined on the basis of lobbying power. And that's what health economics is supposed to do. That's what this new unit of hospinnomics is designed to do, but bridge the gap between decision-making that is based on smoke-filled rooms and under-the-table deals, and does that happen in France? Possibly it does. And something that is a bit more evidence-based. So I hope that the work that Lise is going to be doing in this organisation will fulfil that ambition of bridging the gap between health economics and decision-making to make The funding system, better for the hospitals as a whole, better for the population as a whole. There are technical details, if ever you want to look at them, in this publication. And if you're interested in the most recent report, you can find it and that publication on my website. So you can just find that by Googling my name and put economics in, otherwise you get lots of addresses, which you don't really want. Thank you very much for inviting me to here.